Hello and welcome everybody to another live broadcast with MedStar Health. My name is Mishan Carter and I'm joined today by Dr. Mayan Farha, a breast surgeon and medical director of the breast center at MedStar Good Samaritan Hospital. Dr. Paul Fowler, radiation oncologist and chief of radiation oncology at MedStar Good Samaritan Hospital. And Dr. Massimo Habtesh, a medical oncologist and medical director of the MedStar Health Community Oncology. So October is Breast Cancer Awareness Month, a month dedicated to increasing awareness of breast cancer and the importance of early detection. Breast cancer is the most commonly diagnosed cancer in women. That's why it's important for us to know the risk factors for breast cancer and ways to reduce our risk. So thank you for joining us. Give us a like to let us know that you're here. And if you have any questions, please share those in the comments below. We're going to take some time to answer those as well. All right, so before we begin our discussion, let's meet our experts here. So I'll go around the room and ask you to introduce yourselves. I'll start with Dr. Farha.
Thank you, Mishan. I'm looking forward to this event. I'm the director of the breast center here. We developed a comprehensive breast center that provides all services needed to diagnose and treat breast cancer and to maintain survivorship after patients finish treatment. We're very fond of our multidisciplinary approach. You know, everybody has a multidisciplinary conference, but we really have a true multidisciplinary clinic where our patients get to meet all the providers in the same location at the same time. And we'll have a live discussion about the patient care. A true live experience that has been very useful for our patients. And I'm very pleased to work with an outstanding team of professionals, Dr. Mahabtash and Fowler and others as well.
Well, thank you again. Thanks for joining us. Dr. Fowler.
I'm Paul Fowler. I'm the radiation oncologist in this team. And we have worked, I think, over a decade in having this collaborative breast cancer program, where not only do we see the patients collaboratively, we discuss their cases individually before we see the patients, and we learn from each other as the field of breast cancer oncology is changing literally daily. So it's good for us. It's good for the patients. We all know the same data, and glad to work with these people.
Awesome. That's awesome. Thanks again. And Dr. Mahabtesh.
First, I want to thank Facebook audience for watching this Facebook Live MedStar elaborating on our breast services in MedStar North Baltimore. As Dr. Farha and Dr. Fowler mentioned, we have a very robust breast cancer program in Baltimore region, and we will elaborate more on that. We are here to answer the questions. We are here to provide more information about breast cancer, because I'm sure everybody who is listening to this, either they have been affected or have a loved one, friend, family member who have been affected by breast cancer. So it is good information both for men and women, and we look forward to provide information and answer the questions that you have.
Awesome. Thank you again. All right, so let's talk about the risk factors. Dr. Mahabtesh, I'll start with you. Could you share if breast cancer can be prevented?
So that's a very good question, because I think many people think about this. You know, as you know, there is between 12 to 13% general risk, lifetime risk to develop breast cancer for every woman in North America. So everybody is thinking, how can I prevent breast cancer? So there are some risk factors that we cannot modify, but there are some risk factors that we can modify, and we go into more details about it. But in general, there are ways that we can modify our diet, because low-fat dietary pattern has been shown to reduce the mortality of breast cancer. Regular moderate physical activity can also provide a modest protection against breast cancer. Smoking cessation, not excessive alcohol drinking, they play a role. Those are the things we can modify. However, there are some risk factors, like if you have a history of radiation to chest when you were very young, or you have family history of breast cancer, or you have a personal history of breast cancer, the age, the female gender, those are not modifiable. But I will talk later more about how we can stratify risks, and there are things we can do. And I will talk more about the prevention, how we can do that. But lifestyle modification is always good, not just for breast, for many health issues, including breast cancer and including some other cancers.
Thank you very much. So that ties into my next question. And I think you covered a little bit of this. What are the biggest risk factors for breast cancer?
So the largest risk factor is female gender. You are much more likely to get breast cancer if you are a woman. Age is also a risk factor. The older we get, more likely we can get breast cancer. Breast cancer is very rare below age 35. There are some other risk factors like white race, family history, certain genetic alterations, certain abnormal breast tissue on biopsy, which are not cancerous, but put the patient at risk to get breast cancer, or dense breast tissue. These are not modifiable. There are some reproductive risk factors, like if you had your first menstruation at a very early age, or you went through menopause at a later age, or you had your first pregnancy after age 35, or absence of breastfeeding, or never having given birth to children, those are reproductive risk factors. Obesity in women who have gone through menopause is a risk factor. Hormone replacement therapy in women who have gone through menopause is another risk factor. As I talk, smoking and alcohol consumption are the risk factors. But the biggest risk factor is female sex and increasing age.
All right, thank you very much, Dr. Mohabtesh. Turning over to Dr. Farha, what are the warning signs or symptoms of breast cancer?
The things one has to look for is any new abnormal masses or lumps that one feels. That's why we recommend patients examine themselves once a month on a regular basis. This way they can learn how their breasts feel, and they can tell if there's a difference. The other warning signs could be changes in the skin, redness of the skin. And ulcer of the skin is often advanced, but sometimes changes in the nipple also, in new retraction of the nipple or ulceration of the nipple. And although most nipple discharges are benign, but a nipple discharge that happens all of a sudden, especially if it's bloody and spontaneous, these should alert the patient to seek consultation with a professional who can figure out what's going on.
Thank you very much. Back to Dr. Mohabtesh, how do you determine if someone has a high risk of developing breast cancer?
So by taking personal history, family history, and all those things we mentioned, age of first menstruation, pregnancy, breastfeeding history, there are some models, prediction models that we use a lot, like Gale model or Tyrer-Cuzick model, that they take into account, because each of these risk factors have a different weight, and they take into account the degree of the risk each of these factors carry, and they come up with a calculation. If the risk of developing breast cancer is more than 1.6% in the next 5 years, that woman qualifies for some therapeutics to prevent breast cancer. And there are some hormonal manipulations, some hormonal medications, blocking hormones basically, to prevent breast cancer, but they can prevent the breast cancer which are dependent on hormones. They cannot, the other breast cancer types which are independent or called hormone receptor negative. But for hormone receptor positive breast cancers, they are highly effective, not 100% guarantee, but 40 to 50% risk reduction of breast cancer. So we use these models, we use family history and personal history and a lot of other questions to generate an estimated risk. Of course, this is may not be very accurate, but in general has been effective and has been shown that our prevention can make a difference.
That's great. Yeah, early detection and early prevention, definitely, I would agree, makes a huge difference. Now, you mentioned genetics. Could you elaborate a little bit more about how genetics can play a part in increasing someone's risk for breast cancer?
So most of the breast cancers are sporadic. They just happen. And hereditary breast cancer is usually less than 10% of breast cancers. However, if the genetic testing, we have certain genes that we can test for, and they also have different degree of predisposing a woman to breast cancer. And even if we don't find any of those genes, but a woman has a strong family history of breast cancer, like 2 first-degree relatives have been diagnosed with breast cancer. Even if the genetic test is negative, they are still at high risk to develop breast cancer. So genetics play a role. We cannot always identify the culprit gene, but we have a very expanded panels up to 84 genes that we can check. And for women who qualify to be checked, we recommend that. However, there are many breast cancers which are not dependent on genetics.
All right. And if I found out that I could be at high risk, what's the next thing I should do? What are the next steps for people to take?
So if you are determined to be high risk to develop breast cancer, as I mentioned, there are certain medications we can offer that the person can take. That is called, chemo prevention or risk reduction modifications. And as we talked about, for all women, regardless of being high risk, lifestyle modification is beneficial. And another part that, high risk patients need to be, vigilant about is early detection, as we mentioned. So we can start having like breast MRIs at an earlier age. Breast mammograms are usually recommended, starting from age 40. Some people can start it at age 35 based on their risk. But for younger ages, usually breast MRI is recommended if somebody is very high risk to develop breast cancer. There are other modalities like risk reduction surgeries that Dr. Farha will talk about, that for women who are willing to have mastectomies to reduce their risk for certain genetic mutations, which are very strongly associated with breast cancer, like BRCA1 or 2, or P10 mutations, or P53 mutations. Those are also options. But in general, we can use medications, we can use early detection, we can use surgeries to reduce the risk.
Mishan, as a follow-up on this,
Sure.
we have our imaging department calculates the risk of every patient who's willing to do that. They collect the information and give them a risk estimate on every patient who's willing to do that. And patients at high risk are referred to our high-risk clinic, where our physician assistant working with us, with me, with Dr. Mohabtash, will give patients advice on how to reduce the risk and how to do additional measures for early detection.
That's great to hear. Thank you very much, Dr. Farha and Mohabtash. All right, one more question about screening this time. So, Dr. Mohabtash, how are breast cancers detected?
So the most common and the most recommended method is mammography. It has been lots of studies on this method, and it has been shown to be effective in detecting the breast cancer at an early stage, which translates to survival benefit and decreased mortality from breast cancer. Most of the societies recommend starting breast cancer screening at age 40. We usually recommend it annually, but some guidelines recommended that between age 40 and to 50, it can be checked every 1 or every 2 years. However, many women prefer to have it done yearly. Breast MRI is only recommended for very high-risk patients to use that as a modality for detection of breast cancer. Ultrasound is usually an adjunct way if a woman finds a lump or a physician finds a lump in breast. The other modalities have not been shown to be very beneficial. Self breast exam is not recommended by many societies, scientific societies, mainly because that is for average risk people. People who are high risk, they have different recommendations, and mainly because it can increase false positive results. But clinical breast exam is recommended. Self breast exam, and not necessarily by exam, but every woman should have breast health awareness. They should know their body. So if then anything goes different, they should know about it. And with the first signs or symptoms of it, they have to refer to their physicians, primary care physicians, to be checked for that. But in average risk people, mammography is the best method, starting at age 40, if you're at average risk. If you're high risk, other modalities or earlier age will be recommended.
All right, thank you very much, Dr. Mohebtesh. At this time, I'd like to welcome our viewers again. Thank you so much for taking the time to tune in to this discussion. I'm here with several of our cancer care experts. I have Dr. Mayan Farha, Dr. Paul Fowler, and Dr. Masa Mohebtesh. We're talking all about breast cancer awareness, detection, diagnosis, and treatments, and what the information that you can share with your loved ones for early detection and prevention. If you have any questions, please give us a like, let us know that you're watching, and share your questions in the comment section below. We have much more to talk about. We talked about risk factors so far, also the importance of screenings. I do have a couple of questions that have come in, so I'd like to take some time to answer those. So I have a question from Mary. She's asking, this is what she's saying: I had breast cancer in 2010 and had a mastectomy in my left breast. I was diagnosed with breast cancer in July 2023 and had a second mastectomy 3 weeks ago in my right breast. I'm very pleased with my cancer care team at MedStar Health. So great job to the team. If I can still get breast cancer after 2 mastectomies, why aren't mammograms done? I was advised to do the self breast exams going forward. Both of her cancers were invasive lobular and invasive ductal carcinoma. She says, I never felt any nodules, tumor. Can I insist on getting an ultrasound or MRI annually? So Dr. Farha, I'll direct that to you. If anyone else would like to jump in, feel free to do that as well.
So yes, I want Dr. Farha to respond to this, but before we get there, self-breast examination is not recommended for people, general population, not for a woman who already had breast cancer. So it is highly recommended for those people to have self-breast exam regularly, or for high-risk people. That's, again, it's a different recommendation. So I agree with that part of self-breast examination for this particular person, and Dr. Farha can speak to the rest of the question.
Mishan, the incidence of recurrence after a mastectomy is very, very small. And that could be as low as 2% or less over many, many years. Extensive tumors or patients who have invasive lobular cancer might be at a slightly higher risk than the other patients for this type of recurrence. There are 2 scenarios that play out here. Some patients who don't have any reconstruction. If the patients didn't have any reconstruction, it's really examining the area and being aware of it. And if any lumps are felt, the ultrasound is really a very good tool for evaluating any abnormalities under these circumstances to support the clinician's suspicion or lack of suspicion. Patients who have reconstruction present a different set of situations where the breast MRI comes in very handy, very useful there, especially if they have implant reconstruction. It's very hard to, between the scarring and the reconstruction, it's very hard to find the implants. It's very hard to evaluate, is this a scar or is this a new tumor? And that's where the MRI is very useful there. Ultrasound can be helpful as well. So your patient who asked this question has a very low chance of getting a recurrence, but being vigilant and being evaluated between self-exam and professional exam are key for that patient.
All right, thank you both, Dr. Mahaptesh and Dr. Farha. And thank you, Mary, for sharing your question and your experience with us. I have another question from Heather, this is what she writes. I have been having my right breast, it's really tender. What could that be? I believe it sounds like she's doing self-exams. She said sometimes it leaks out clear stuff and she doesn't know of any family history. So what are her next steps? What do you recommend that she does?
Sorry, I had a call from the patient has tenderness in her breast.
Mm-hmm.
How old does she say her age?
I don't have the age, but she says it's happening in her right breast. Sometimes it's leaking clear liquid, and she doesn't know of a family history of breast cancer. But what should her next steps be?
This patient is symptomatic. She has localized pain on one side only, and she has a nipple discharge. She needs a diagnostic workup. She needs to be seen by a breast care specialist. Most often these patients see the surgeon who might refer them to a diagnostic mammogram and ultrasound. These would be ideal for this type of patient. This is a good starting point for them.
All right, thank you, Dr. Farha, and thank you, Heather, for taking the time to share your question and your experience with us. We hope that you're doing well. At this time, I'd like to turn over to some of my questions. So we talked about risk factors, we talked about screening. Now I'd like to dive into breast cancer diagnosis. So Dr. Farha, I'll direct this to you. How is breast cancer diagnosed?
The vast majority of patients nowadays are diagnosed through a needle biopsy. The needle biopsies are the workhorse of breast cancer diagnosis. They made life so much easier for the patients instead of going under anesthesia, having an incision, much less deformity. And the needle biopsies are highly sensitive and specific. We get the answers in almost all the cases. For large palpable masses that we can feel that are large, we do the needle biopsy guided with the hand. Once we inject a good bit of numbing medicine, once the patient is very numb, we have specialized needles that goes in, takes tiny samples that we send to the pathologist, and they almost always give us the answer. Now, the majority of patients nowadays are detected by screening mammography or ultrasound. And in these circumstances, again, it's a needle or what we call a minimally invasive biopsy. For ultrasound lesions, we do an ultrasound guided biopsy, meaning often the radiologist in most cases, but some of us, like myself, we do our own biopsies as well. With the ultrasound guiding the needle, we'll place the needle into the lesion and get samples from that lesion. And that almost always works for us too. Now, there are lesions that are detected by mammography only, such as calcifications. Then mammography will guide the biopsy, and that's called a stereotactic biopsy. Again, a minimally invasive biopsy, leaving minimal scarring, and these are well tolerated and avoid a trip to the operating room. Now, there are a few patients who have MRI lesions that are diagnosed with an MRI guided biopsy as well. So we rarely have to take a patient to the operating room to make a diagnosis. That's very unusual.
All right, and Thank you very much. So let's talk about the stages of breast cancer diagnosis. Could you share more about that and explain the different types of breast cancer?
So when we see a new breast cancer patient, the first thing we want to know is the extent of the disease and the type of the cancer. And that drives the treatment and the treatment plan. So if I see a patient today, the first thing is doing a good history, a good physical exam of the patient where we estimate the size of the tumor, the location of the tumor spread to the lymph nodes. But then we review the imaging, again, try to decide the same factors, the size of the lesion, and if the lymph nodes were evaluated or not, to see if the tumor spread to the lymph nodes. We screen the patients for any symptoms of spread to the rest of the body. Once we do that, we have an idea of an estimated stage, and that estimated stage, we call it a clinical stage. Some patients are sent for additional imaging, breast MRI or CAT scan or a PET scan. These are scans that check if the tumor spread somewhere else. And then once we get that piece of information together, we say this patient has the earliest stage, the precancer stage, stage 0. This is called DCIS, ductal carcinoma in situ. Uniformly near 100% cure rate. There we focus on treating the breast mostly. Then stage 1, it's when the disease is small and confined to the breast. That also has a high cure rate in the high 90s, 90%. Then you go to stage 2, where the tumor is either larger or spread to the lymph nodes. These also have a high cure rate. Then you go to the stage 3, where it's extensive disease. That's a different treatment plan altogether. Stage 4 is when the cancer has spread to the rest of the body. The good news is that in the past, that used to be an end-stage disease. Nowadays, Dr. Mohabtash and Dr. Fowler, and sometimes ourselves, we have so many options for these patients that we can give them comfortable, long survival. And we've seen patients live many, many, many years comfortably after treating stage 4 breast cancer. So this is what you want to do, is try to detect the patients at stage 0, stage 1, where again, the cure rate, the 5-year or 10-year survival is over 95%.
Thank you very much for explaining that. I'd like to talk about treatment now. Dr. Farha, could you share how breast cancer is treated?
So once we have looked at the stage of the patient, we convene our team. We sit down around the table with our radiology colleagues, with our pathology colleagues. We get our social workers and everyone, research nurses, and we sit around the table, we discuss the patient, and we define the clinical stage of the patient. We agree, all of us, on one stage that drives the treatment. And then we say, some patients, there are 2 broad categories of patients. Some patients have great benefit from getting preoperative chemotherapy, and some patients need surgery first. So in that meeting, we decide the track which we would recommend for patients. In principle, if you want to think about it, the 3 things you want to address is how to treat the breast itself to prevent recurrence, then how to evaluate the axilla where the tumor spreads, and then how to minimize the chance of the cancer coming back in the rest of the body. Treating the breast and the axilla are largely done surgically with radiation, although medical interventions such as chemotherapy, immune therapy, targeted therapies help with that as well. So for each patient, we fashion a treatment plan based on the extent of the disease in the breast, whether it's spread to the lymph nodes, and what are the chances of this disease showing up in the rest of the body. And depending on the type of cancer, then decisions are made: chemotherapy first, surgery first, what happens after surgery, which patients need radiation and can benefit from it, and which patients need after surgery, post-operative chemotherapy. We call it adjuvant chemotherapy. It's really a complex algorithm, but if one focuses how to minimize the chance of the disease returning to the breast, how to check the armpit and prevent the disease there, and how to prevent the disease from showing up somewhere else in the body. Once we put these things together, we create a plan for the patient. We share it with the patient. Sometimes patients have a lot of choices, which obviously we help them making the decision.
Thank you very much, Dr. Farha. So you mentioned surgery as a component of treatment, depending on the patient. Are there any minimally invasive options for breast cancer surgery, and are there any side effects that people should be aware of?
So for patients, a large majority of patients can be treated either with a lumpectomy and radiation versus a mastectomy. The cure rate for these two modalities in properly chosen patients are the same. Actually, there are some patients who might not need full breast radiation, and we treat many patients with partial breast radiation. A lumpectomy is really in appropriately chosen patients is taking enough tissue to take the tumor and surrounding margin around it. For the patients who have very small tumors that are favorable, Dr. Fowler and I could do intraoperative radiation where the patients finish their surgery and radiation in one procedure. Other patients may need radiation where Dr. Fowler will offer the radiation after they heal from the surgery. And that radiation has been changed from the usual 6 weeks. Sometimes they offer it over 3 weeks. Some patients need the whole 6 weeks, but again, it depends on the case and depends on the extent of disease. So I'd say the large majority of our patients end up with a lumpectomy, which is a small procedure done as an outpatient, and many of them get intraoperative radiation, and some get accelerated radiation where they get the radiation over 3 weeks.
All right, that's good to know. So you mentioned breast reconstruction as well. Is that also a part of the treatment process? And could you elaborate a little bit more about that?
So the purpose is to maintain the breast and the contour of the breast as much as we can, focusing on making sure the cancer has a very low chance of coming back. So we always interact with our plastic surgery colleagues, even for partial removal of the tumors. So for lumpectomies, patients who have larger tumors or are located in different places like under the nipple or medial part of the breast, the plastic surgeons come into the surgery with us and they reconstruct the breast for us to make the appearance of the breast as close to what it was before the surgery as possible. Now, for patients who have a mastectomy, if their health allows, these patients are evaluated by our plastic surgeons, and these are offered largely one of two types of reconstructions, either implant reconstructions, which is what the majority of patients get, or own tissue reconstruction, like free flap reconstructions. Both are offered to patients. Now, of course, we have to exercise judgment in these cases. Somebody with a lot of comorbidities, smoking, having own tissue reconstruction, or it might not be the best choice for them. And there are some patients who have very favorable circumstances where we could do something called direct to implant reconstruction, where the reconstruction is completed, that the implant reconstruction is completed in one step. The implant is placed over the muscle without having to move the muscle. And the recovery in these is excellent. It's so easy, minimal discomfort, and one-step reconstruction. But not every patient is eligible for that.
All right, thank you very much, Dr. Farha. At this time, I'd like to turn to Dr. Mahebtesh. As a medical oncologist, how do you treat breast cancer? Could you share a little bit more about your role, and are there any new treatments available?
Yes, we have many modalities in the field of medical oncology to treat breast cancer, and it falls into many different categories and for many different stages and breast histologies. For example, we have from risk reduction, as we talked about, to treatment for stage 4. Depending on the type of the cancer, we can incorporate chemotherapy, hormone blocking therapy, targeted therapy, or immunotherapy. But not all of them may apply to one patient. So we look at the patient's cancer type, histology, markers, stage, prior treatments, and patient's tolerance, patient's factors. Not everybody is a candidate for chemotherapy. Not everybody can get certain kinds of anti-hormonal therapy. We have many different ways to treat breast cancer systemically, partly to treat the cancer sometimes before the surgery to shrink the tumor, sometimes after the surgery just to prevent the cancer recurrence, and sometimes just to reduce the risk. Sometimes we are not needed at all. Like, sometimes patient doesn't benefit from any systemic treatment. For example, if a woman has non-invasive breast cancer and has double mastectomy, she doesn't need any systemic treatment to reduce the risk of cancer recurrence. So it's very individualized.
That's good to know that the treatment care, the care plan is individualized. It's customized to that person as an individual, taking all of their history, risk factors into account. That's really good to know. So thank you very much, Dr. Mahebtesh. I have another question. This is related to clinical trials, and also, if I could tag this audience question onto it as well, Dr. Mahebtesh, could you share, are there any clinical trials available for breast cancer? And we have an audience question also related to research. How are research studies coming along as far as chemo and radiation and treating breast cancer?
Excellent question. There are numerous clinical trials ongoing for breast cancer, from the spectrum of early detection, prevention, treatment for early stage, treatment for later stage, survivorship, stage 4, breast, medical oncology, and radiation. So, and also some of the clinical trials are just directed to deal with complications and side effects of the treatment. Here at MedStar Network, we have 28 clinical trials as a network for breast cancer in many different stages. And we have 8 of them open in Baltimore, open to our patients. Every time a new exciting clinical trial is presented, we try to see if it benefits our patients, if we have eligible patients for that, and we try to open it. So our research team is very active, and we have many clinical trials for our patients.
Awesome, that's good to know. And thank you, Terry, for sharing that question as well. Right now, I'd like to pull Dr. Fowler into the conversation as well. Dr. Fowler, could you share what is the role of radiation oncology in treating breast cancers?
Well, radiation is a local treatment, and it's similar to surgery and often used in addition to surgery. The largest role I have is in breast conservation therapy, where early stage breast cancer is treated with a lumpectomy. And instead of doing the mastectomy, we give radiation to the intact breast. And as Dr. Farha previously said, we used to do that over 6 weeks, and now we do it over 3.5. So we're able to do this, get the same result with treatment, so it's more convenient for the patient. The other place where radiation plays a role in local treatment is when lymph nodes are involved or the tumor is large, either with or without a lumpectomy, an adjuvant setting where we're going behind usually chemotherapy and surgery to eradicate any cells that may be left behind in the local area. That treatment is characteristically spread out over 6 weeks as opposed to the 3.5 weeks, and involves not only treating the breast, but also the regional lymphatics under the arm and in the neck, the supraclavicular region. These collaborative meetings that we have are very helpful because, as Dr. Farha and Dr. Mahabtesh have already stated, discussion of what we think the disease is from the very beginning, and sort of in our mind's eye have what we're going to recommend to the patient, and discuss and present the possibilities to the patient, and then support them in however they wish to choose to be treated.
Sean, there's also a very important role for palliating symptomatic metastasis sometimes also, or brain metastasis, controlling brain metastasis. Dr. Fowler comes in very helpful with some of these as well.
And just like everything else in breast cancer is changing, radiation for metastasis, it used to be, as Dr. Farha said earlier, when people had stage 4 disease, we thought we weren't going to be able to give them long-term survival. But in certain subsets of patients where they have just a few metastatic lesions, we can treat them with very focused radiation, SBRT, and eradicate that disease and provide them a long-term survival with local treatments.
It's good to know. Thank you very much. Dr. Fowler, my next question is about IORT. Could you share what that stands for and who is an ideal candidate for it?
So IORT stands for intraoperative IO radiation therapy, IORT. And as it sounds, in the surgery, Dr. Farha goes in, finds the tumor, removes it. We put a balloon in where the tumor was, we inflate it and make sure it's positioned properly. And while the patient's still asleep, we bring a machine in that gives the radiation just to where the tumor used to be. The nice thing about that, obviously, is it's all done while the patient's asleep. They don't have to come back and forth for 3 weeks, 4 weeks, 5 weeks, whatever. It is not for everybody. We want a very favorable tumor, a small tumor, a tumor in a person who's postmenopausal, a tumor that has estrogen and progesterone receptors, a tumor that does not express HER2. So it's something that we have and we use it and we love it and we're great. It's a great thing to have, but it's not for everybody.
It helps also with some patients who are unable to complete whole breast radiation for some reason, or unwilling to go through whole breast radiation. So we're trying to help patients and see what they're able to do and what can be achieved with each patient.
Exactly. Thank you very much. Dr. Fowler, are there different types of radiation therapy available for breast cancer?
Well, so it's all radiation. There's different ways of delivering it. IORT was one of the ways we've already talked about. The traditional radiation is usually done with photons. For some patients' breasts and in some locations of the breast, the physics of the radiation beam is such that we can't use the photon radiation, and you might need to use protons, which we have access to as well. But it's all radiation, and occasionally we'll even do partial breast radiation where we just treat where the tumor was, but over 5 days as opposed to 3.5 weeks. But again, that's a very select patient population.
Okay. And could you also share what are the benefits of radiation therapy?
The largest benefit in the breast conservation fashion is that you get to maintain your breast. And I always tell my patients, I'll be happy, you'll be happy if 6 months after the treatment, the breast looks as good as it did before we started, okay? So we want to get rid of the cancer and we want to have a good cosmetic result. So that's the huge benefit. In the adjuvant setting, it increases survival. When we're giving radiation, because it is spread locally and we're sort of mopping up where the cancer was with radiation, that increases survival. So the benefit is survival in that setting.
That's awesome. And could you also share how long does a usual course of radiation therapy last?
In a breast conservation treatment where we're keeping the breast, anywhere from 3.5 weeks to 4 weeks in a day. So it's about 20 treatments. In an adjuvant setting where we're treating the chest wall and the lymph nodes, that usually goes on for about 6 weeks. The treatment itself lasts maybe 3 to 5 minutes. They're in the department about 10 to 15 minutes. Most people can come to the radiation. It's a daily treatment, Monday through Friday, 5 days a week. Most people can come to the treatment and go back about their day. It's not going to make them sick. It's just a local treatment. It's a nuisance, but it's not terrible.
All right. Great to know. All right, Dr. Farha, why should someone choose MedStar Health for breast cancer treatment?
Well, actually, that's a good question. For ourselves, for our center here, I think we have the unique experience of working together as a team so closely and over many years now, and working as a team in a multidisciplinary clinic, not just a multidisciplinary conference. As you can see from this discussion, there are so many choices and so many routes a patient can take or a patient should take. And then you have, in addition to ourselves, sitting together, going through the details and figuring out what's the optimal treatment for a patient. That's really not an easy thing to do unless you work together very closely the way we do. Then after that, you have to go to the patient and make sure they understand why are these the only two paths available to them. And that's a process where when we sit down and talk to the patient, the three of us with our support staff, there's a live discussion. The patient asks question. We may disagree. We may have a little discussion, say, why don't we do this? Why don't we do that? That treatment plan is refined in a real life way, in a live way. And the patient, seeing that good discussion, will understand why we're asking somebody to do some tough decisions like having major surgery, having chemotherapy, having radiation. So that's for our location. But if you think of the network as such, we have the same multidisciplinary conference and discussing of cases. We do that regionally, and Dr. Mohabtash is in charge of that. So we benefit from each other's expertise. We have a wide geographic coverage, starting from Bel Air to Good Sam, Franklin. We cover Harbor as well. And for specialized situations, we have access to Georgetown resources as well in terms of clinical trials, proton therapy, and so on. So I think the network has a good geographic coverage, has a lot of resources that we try to benefit our patients from. I think this is a strength that we have.
I totally agree with that. Thank you very much, Dr. Farha. Dr. Mohabtash, if someone has been diagnosed with breast cancer, should they get a second opinion?
It's always good to have a second opinion. However, if your breast cancer is very classic, very typical, there is no controversy, you are comfortable with your treatment plan, you are comfortable with your care team, you may want to bypass it, especially in the settings that treatment needs to be given before surgery, like we call it neoadjuvant or preoperative treatments, and the treatment should start as soon as possible. So if getting a second opinion may delay your treatment, or you are not as much doubtful about which way to go, it's okay to go with treatment without a second opinion. But if there is some areas that is not sure, your care team is debating, and sometimes you are referred to second opinion by your care team, and they want another person to take a look, to have another perspective. Sometimes we are looking for clinical trials which may not be available in our system. So of course, any decision is made mutually with the patient and the care team. But it depends. The right answer is that depends on the situation. Yeah.
Thank you very much. And my last question, I'd like to direct it to all of you on the panel. As we close, what's your final message that you'd like to share to our viewers? Dr. Fowler, I'll start with you.
I think if you've listened to this for the last hour, you will realize breast cancer is extremely complex. And even if it seems like your cancer is the same as your friends, there's probably some important difference. It requires the input and consultation with a bunch of specialists to, first of all, understand exactly what they're dealing with, but then to discuss with the patient, hopefully real time, like we're able to do here, what we think is going on and what the treatments are. So it's complex. You need to involve the entire treatment team: medical oncology, surgical oncology, radiation oncology, pathology, radiology, genetics, and do it quickly because you want to get your treatment started as soon as possible.
Absolutely. Time is of the essence when it comes to this. Thank you very much, Dr. Fowler. Dr. Farha, what's your final message to our viewers today?
I want to focus on the timely treatment, actually. I've been looking into this because there was a period where we would say, oh, well, a few weeks delays and stuff like that is not a big deal. There's been, especially with the pandemic, people have looked at that, and delays have really led to increased mortality, significant increase in mortality for breast cancer. So the things that I'd like to be our focus is trying to promote early detection. If a patient has a symptom, please act on it. Even if a negative consultation where the doctor says it's okay, there's nothing wrong with that. A doctor will never say, why did you come here? We'd say, come, we want to make sure you're okay. But then the other factor is, this is a very tough experience for the patients, not only physically, mentally, emotionally. So gaining support from family and friends, from your support, is very, very important. And I think the next dimension, which is really important, is putting the patient together when they complete treatment. I find some patients do it of their own accord, but I think many patients need much more help. And we need to be more thoughtful about how to enable patients to optimize, go back to their baseline functioning status while minimizing the chance of the cancer coming back. These are the things in my mind that are really very relevant and important for the care of our patients.
Thank you very much, Dr. Farha. And Dr. Mahatesh, what's your final message to our viewers today?
So besides what Dr. Fowler and Dr. Farha said, I think that every person needs to be cognizant of the risks that we all encounter to develop cancer. This is Breast Cancer Awareness Month, so I'm talking to men, women, and some men also are at high risk for getting breast cancer, depending on their family history and genetic alterations that some people may have. But follow up with your primary care very regularly. Be on top of your screenings. Listen to your body, know your body. Seek attention if there is any symptoms. Do not delay it. And do not deny a symptom. And remember, breast cancer, if it's detected early, is highly, highly curable. Do not miss that window. If you are a breast cancer survivor, as Dr. Farha mentioned, we are here for you to take care of whatever residual side effects or complications from treatment you have. And of course, you would be at higher risk of developing another breast cancer. So make sure you're on top of every single test that is needed to be done for you. And there is always evolving and new treatment options for breast cancer coming, for breast cancer detection, for screening, for prevention. So being in touch with your care team put you at the top of the line, to know what is available for you.
Very important words to consider. Thank you very much for that message. And thank you all for joining us. That wraps up our broadcast today. Thanks to all of our viewers for tuning in and spending time with us and also sharing your questions with us. We really appreciate it. Many thanks to our panel of experts, Dr. Mayan Farha, Dr. Paul Fowler, and Dr. Masa Mohebtesh for spending time with us today as well. We really appreciate you sharing this important information. Really thank you for spreading awareness about all of this. For more information or to schedule an appointment with us, please call 443-444-4673. We're going to put that number as well in the comments of this Facebook Live. Thanks again for joining us and have a great day.